Well, thank you for inviting me, and I apologize for not being there in person. I had a run-in with a COVID PCR test that inadvertently came out positive, which I thought was not accurate, so I had it retested, and it came out the same inaccurate way. So that's why I'm quarantining for 10 days, but I will be back at work on Saturday. That's when I'm allowed to come back. But I'm going to speak on arachnoiditis and syringomyelia. And let's see if I can get this to advance. All right. So arachnoiditis causes scarring around the spinal cord. You see this crosshatch? It's really scarring in the subarachnoid space. It refers to the arachnoid membrane, which is here. If it gets more severe, then it affects the subarachnoid space, and if it gets most severe, then it affects also the pia, and it bridges across that space. The normal situation is you have a clear subarachnoid space here. So even though it's called arachnoiditis, the severe form affects the subarachnoid space and the pia membrane, which is the membrane that rests on the spinal cord. And arachnoiditis develops after inflammation in the cerebrospinal fluid. So what causes inflammation in the spinal fluid? Well, it could be infection, bleeding, injected chemicals like an old type of myelogram dye. Surgery, even though we don't like to admit it, can cause inflammation, and trauma like severe motor vehicle accidents can cause arachnoiditis. And arachnoiditis is scarring. It's another name for scarring. And if the scarring affects the CSF pathways, you get syringomyelia. If it's the pial membrane, which is on the spinal cord, it reduces spinal cord blood flow. And if it's on the arachnoid membrane to the pial membrane in the spinal cord, then that tethers the spinal cord. So when you move, it injures the spinal cord, because the spinal cord usually moves in a different way than the spine does during movement. So arachnoiditis is like a great party for cells. You know, it's like there's an injury, and then pretty much the word goes out that there's free beer there. So all these cells come in, these inflammatory cells, because they want to close up the injury, and then there's usually a little bleeding wherever there's an injury, and this fibrin, which is the clotting factor, that comes in there, and then you form a clot, and then these fibroblasts, they respond to these clots, because say if you cut yourself with a razor or whatever, a knife, you want these fibroblasts because you'd want something to cover the wound so you wouldn't get infected, and then you get all sorts of other cells, and that forms the scar tissue. And depending on your genetic makeup, you can have either a scar that that resolves completely, or you can have a scar right across the subarachnoid space and have arachnoiditis and have syringomyelia. So it's all individual. There's a term that's used, it's called adhesive arachnoiditis, and adhesion just means sticking force between two surfaces. So if just the arachnoid, one membrane is a little bit larger or inflamed, that usually doesn't cause a big problem. But if you have adhesive arachnoiditis, that's when the arachnoid membrane sticks to the spinal cord and these blood vessels and the pia. That's a much more serious problem because it blocks the spinal fluid flow. Now, there's a term in the literature it's arachnoiditis. Everybody who's had lumbar back surgery and has low back pain says they have arachnoiditis. So that's an incorrect use of the term, but we really can't get away from it. And so people will say, well, I have arachnoiditis, but that's just scarring outside the dura. That is not scarring inside the dura that I'm talking about today. So, some people can have trauma and they'll never have arachnoiditis. Some people won't even know they had trauma and they'll develop arachnoiditis. So we know genetics is involved. And of course, genetics is involved in everything. But what do I mean by genetics is involved? Well, genes either regulate proteins, and the proteins that I'm usually talking about are enzymes. So they regulate metabolic processes. So if you have a process that creates fibers and scar, if you have a little difference in that pathway because of your genetics, then you'll make more scar than the next person. And the other thing is you could just make these structural proteins that are a little bit stickier than the next person. And we know there's a genetic component to arachnoiditis because there's some families where over generations people develop arachnoiditis. And so this is a family from Japan, and some of these people later emigrated to Vancouver, Canada. But you could see this woman was affected. Rounds the woman, squares the man. So grandmother had it, son had it, 3 daughters had arachnoiditis, and the father gave arachnoiditis to one of his sons, obviously inadvertently. So you can be predisposed genetically to arachnoiditis. Here's another family that was reported more recently in Belgium, and this is in 2 generations. You can see a brother and a sister, and then the sister had a daughter with it, and the man had both a daughter and a son with arachnoiditis. So there is a genetic component to it. And in the Belgian case, you can see here, just this person was predisposed to forming this band here, and you can see the band going across the spinal cord on the MRI scan, and you can see this big syrinx, fat syrinx, I should say, superior to it. And, you really can't take the part of the membrane that's on the spinal cord. You have to leave that because, otherwise you'd have some neurologic deficit. So, that's one of the reasons it's called arachnoiditis, because that's the arachnoid part you could take and send to the pathologist. And pathologists, we stain with what's called H&E, and if fibrous tissue ends up being this nice pink color, and that's so you could see that this person really has a thick membrane and a lot of fibrous tissue. Now, here's a report of a veterinarian who uses the microscope, and you can see that the dogs have fibrous bands too, and you can see they pick it up and they cut it. So really you treat, and you can see here the spinal cord's swollen, and this is where the band came across, so it's relieved, and they sew it up. But the thing is, dogs are smaller than people, so that was really great surgery. So the arachnoid membrane, that's the outer membrane. It gets a little thicker as you get older, but the people who have thicker arachnoid membranes, they have more fibroblasts. Those are the cells that make fibers. They have more macrophages, which are cells that go to clean up debris and are involved in the immune reaction, and increased vascular endothelial growth factor. And that's just a factor that brings blood vessels in. So you could see that if you had mutations or differences in genes related to any of these, that your scarring process might be more exuberant. Now, arachnoiditis can be either focal, which is what I pointed out in that one genetics case and the dog, or it can be extensive, extending over 4 or more vertebrae. And it can be limited to behind the spinal cord, or it can extend around the spinal cord. So the less you have, the better your prognosis. And when syringomyelia accompanies arachnoiditis, the implication is that the CSF pathways are blocked. And generally, say after a severe trauma, the syrinx develops about a year or later afterwards. And it's a delayed process because it takes a while for the syrinx to develop. And the thinking is that you start with a small syrinx and then it gets larger and larger. And once, say in this example, once it gets out to the side, then you would lose some sensation over there or on that side of the body. And you might have some chronic pain there. And then you would go for medical attention. The treatment of arachnoiditis and syringomyelia is through laminectomy. Some people use laminoplasty, and I have in the past. If you do multiple levels, sometimes the surgeon decides to do a laminoplasty. But everything is the same up to this point. If you're going to have what's called a lysis of adhesions, that means cutting the scar bands, or lysis of adhesions plus putting in a shunt tube or just putting in a shunt tube. So you have to do all of those operations through a laminectomy. And so there's a preference for not putting in shunt tubes unless they're absolutely necessary. And I say, well, why? What is absolutely necessary? So absolutely necessary is if you can't open up the spinal subarachnoid space by any other method. So a shunt is really a treatment of last resort. You're acknowledging that you're not going to open up the CSF pathways any other way. And there's good data supporting this approach because shunts don't last very long. This is Dr. Batzdorf and Kleekamp, who are just awesome surgeons, and no one's better in the world as far as I'm concerned. And so even in their hands, it's 6 months. At 6 months, half of their shunts will fail if they're put in at the level of scarring. And if they put the shunt in at different from the level of scarring, so you go at the 50% mark, it's less than 2 years of relief that these people have. And syringomyelia is a chronic disease, so that's, there's a lot of 2-year intervals till the end of someone's life, and with syringomyelia. We wanted to learn more about arachnoiditis and syringomyelia, so we performed a study at the NIH, and half the patients had post-traumatic syringomyelia. Two had meningitis, one had a panopaque myelogram, which is a chemical, but 14 people didn't have any previous surgery. They all had the expected problems you would have, like loss of sensation, weakness, pain, spasticity, and then the ambulation. Almost half of them had some problem with ambulation. And we just evaluated them clinically before and after. We did MRI scans. We did CSF flow studies, also measured their pressure. And these were some of the patients here. This person on the left had a very large syrinx. He had a motorcycle accident when he was a young person. And then he worked on computers, and his hands started not to work very well, and it was because the syrinx came up from the thoracic area. So that added, the arms and the hands into his previous paraplegia. So that made things a lot more difficult. And then this was a person who had a previous infection, and she had a much more limited syrinx. And then we had people like this who just had lesions. The spinal cord is supposed to look like a football. This compresses it so it looks like a pancake, and then above the pancake, so that was down here, and above the pancake was this syrinx here. So, we did the flow studies, and in the area of the syrinx, this black area, this is CSF flow, and so in the area of the syrinx, there was no flow outside the spinal cord. And so after surgery, the syrinxes got smaller for the group as a whole, and most people were the same or maybe a little better immediately after surgery, but we realized at last follow-up, which was like about 4 years later, that some of these people fell off as far as their ambulation. I mean, when we operated, 53% were normal ambulators, but at 4 years later, it was 36%. And some of them, were still using canes and stuff like that, but some people had become non-ambulators. So even though we had done surgery, as I said, with arachnoiditis, the process can continue, and the effects of surgery are seen by the body as a trauma. So, that's one mountain that's left to climb as far as treatment of arachnoiditis. We looked at our results, and the people who we thought had a good clinical outcome, there were 28 people like that, and they had a good clinical outcome because they were the same or a little better. And those people all had reduction in their syrinx size and length, and all of them before surgery had less than 3 spinal levels involved. On the other hand, people who did poorly, their syrinxes didn't get any smaller after surgery. The length of the syrinx didn't get any smaller after surgery. And as I said before, as far as syrinx size was concerned, the more laminectomy levels we did, the less effect we had on syrinx size. So the people with less disease did much better. As in this case, if you have something like this, you have a lesion, it's located behind the spinal cord, so it's just looking right at you, ready to be removed. The spinal cord looks good afterwards. We did a duroplasty on all the patients. I don't think we would do that anymore. And you can see after surgery, the CSF flow gets by the point where there wasn't flow before, but you can see now there's good flow around the spinal cord, not into the spinal cord. And, if you restore flow, you can see here, the black area is the syrinx. So the syrinx will go away. In this type of series, the syrinx is in white, and you can see that there was no fluid around the spinal cord. Now there's fluid around the spinal cord, and the syrinx is small. And really, in these cases, the white area just indicates what the syrinx injured while the person had it. So, I'm just reporting what other people have reported, but I think we maybe put a finer point on it and nailed down the number of levels. But so for focal arachnoiditis or trauma, you have good success at opening up the spinal subarachnoid space. For extensive arachnoiditis, their success rate is much lower. And the main thing that determines success is if you're able to open up the CSF space. And even if you are able to open it up temporarily, are you able to open it up long term? For this tough group where they have over or 4 greater levels of arachnoiditis, we're trying to expand what we can do just with laminectomy. And So I'll just show you a little movie. Some people might have seen this before. But you'll get you get an eyeful, as my mom used to say. Okay, so this is the surface of the spinal cord with the blood vessels. And then the dura and the arachnoid are on top. And you can see, like, you're basically going into the cave. And if you're going in this cave, you'd be heading in the other direction because you figure you might not find your way out, you know? So anyways, the normal situation would be this space would be wide open, but you could see here then into a little hole here. And really there was no hole to start with, so we put our scope down there and like an icebreaker, we broke up some of those bands of scar. So we just keep going till we find water, you know. So we get to an open space, and then it's connected, and then after that we widen it. All right, let me see. Enough of that. Okay, so you see this band here that I showed with the dog before? Well, this lady had failed previous surgery. You could see that because she had this laminectomy before. So we were able to release the lamina and get the CSF to circulate a little bit better above and below our lamina. And we reported that our first 10 cases using the endoscope in Journal of Neurosurgery in 2021. You know, everybody's trying to improve and to be introspective and try to think of ways that patients with extensive arachnoiditis can be treated better. But what we're doing is really just replicating each other's experience. And so this is arachnolysis, and this is in France. So you can see this is how long it takes before the people need to have a second operation in France. So here you have about 120 months. So it takes about 10 years in France to have your second operation if you have your scar cut, whereas you have about 4 years if you get shunted. And if you compare the focal versus extensive arachnoiditis, you can see that the people with the focal arachnoiditis do better, whereas people with extensive arachnoiditis, all of them fail, which means they need another operation. So, as I said, we need better treatments to prevent recurrence of scarring. What we have now is dexamethasone. Every time I want to use it, there's always somebody who said they had psychosis before, they have diabetes, obesity, and dexamethasone can cause other complications. So it would be nice to have more targeted treatment. It would be nice to have to really have tailored treatment so we know going in the genetic makeup, what caused the person to have scar in the first place, but we're a ways away from knowing that. So no man is an island, as John Dunn said, and most of these people did more work on the project than I did probably. But so thank you for your attention, and I appreciate you allowing me to speak, even though I couldn't make it out there.
Hi, John, it's Patrice. We're going to do a Q&A now with you, okay? John.
Dr. Heiss, can you hear us?
I can a little bit, not real well. I hope you could hear me better than I can hear you.
Okay. Is that any better now?
Yeah, that's better.
Okay. We're going to start the Q&A for you now.
Could you do me a favor? Could you just write the things in the chat?
That might be difficult. Can you hear us any better now? Is it improving at all?
All right. If somebody could say it and then write it in the chat.
Okay, we can make that happen.
Thank you.
Questions for Dr. Heiss? This might be,
Hi, how helpful are spinal cord stimulators for someone with syringomyelia for their pain?
Can somebody put that in the chat? I
Thank you.
apologize again.
Well, let's see if Dr. Heiss wants to answer.
Yeah, and just, okay, how about stimulators for people with SM for pain? Yeah, stimulators are not disease modifying. In other words, they control symptoms. So there's nothing wrong with controlling symptoms, obviously. So you just have to realize that, and on the other hand, it's not like you're confronting the other condition and making it worse. So stimulators are fine. They're symptomatic treatment. They're somewhat invasive, but if done by someone with skill in doing them and inserting them, I think it can be a good idea. You generally move from least invasive to more invasive, depending. So generally, stimulators are used if other methods don't work.
Thank you. We'll get to that question in a second. There's another question. John, if you can read it in the chat box. You can barely hear us. I understand.
You guys are so nice. Could you just write it in?
Yes, we're just finishing typing it now. Here you go.
Not all inflammation is the same. Thought at phenotyping inflammation Th1 versus Th2 to have better therapeutics. Are you referring to different types of T cells, or what are you referring to?
You can probably speak up into that laptop. He can hear you from there.
But anyways, mast cells. Yeah, mast cells are okay. Mast cells are becoming of greater and greater importance with the whole immune reaction. And I am not an expert at mast cells, but I'm a great respecter of people who are. And mast cells are, just because I don't know a lot about it doesn't mean that other people don't. But I still think that it's an expanding field and that great advances will be made in the future about that.
Yeah, that's good. I mean, John, we don't want to put you on the spot on all these things, but thank you for trying to answer this. Any other questions, Dr. Heiss, before we, yes, we're going to type another question. John, there's another question coming, so just bear with us. We're going to type it in a second. So in the meantime, I'll tell you about the spinal cord stimulation, because spinal cord stimulation is great for pain, but for whatever reason, it does not work for cases when pain is caused by spinal cord dysfunction. So it doesn't work for pain from syringomyelia. It doesn't work for pain from brachial plexus avulsion. So there are many conditions where spinal cord stimulation, unfortunately, does not work. I mean, I know some people report good results, but we tried it many, many times, and it inevitably fails in every patient. So in as much as I want to use this modality for being non-destructive and attractive, and it just has not worked in our syringomyelia patient population.
Does arachnoiditis and syringomyelia go hand in hand? Yes. Don't get syringomyelia unless you block the spinal subarachnoid space, or you affect the spinal cord sufficiently to create more fluid production or lack of absorption from the spinal cord. So the arachnoiditis has to be sufficiently severe to either block the subarachnoid space or cause some fluid creating condition in the spinal cord, such as what's called ischemia, which means low blood flow.
Good. Thank you very much, John. Thank you very much for answering questions. Let's give a hand to Dr. Heiss.
I appreciate your forbearance and have a great meeting. Thank you very much.
No, thank you for being with us.